Hello and welcome to the Clinical Liver Disease video series. CLD is the official digital learning publication of the AASLD. I'm Lily Dara from the University of Southern California, here with Dr. Bob Fontana from the University of Michigan to discuss the article he recently contributed to Clinical Liver Disease titled Immune-mediated liver injury from checkpoint inhibitors, best practices in 2024. Hi, Bob.
Hi, how are you doing?
Great. Thanks for agreeing to doing this. I read your article. It was really fantastic, a really timely summary of best practices right now. And I just wanted to go through a few key questions for the audience, some takeaway points. So the first thing I'd want to ask you is if you could just describe to us what is LEC, why you abbreviated this way. I know there's a lot of different terms used for checkpoint inhibitor hepatotoxicity. How common is it in cancer patients receiving checkpoint inhibitors, and just introduce the topic.
Sure. Yeah, I agree. The nomenclature is sort of evolving, if you will, right? I think those of us in the field who do research like this, like you and I, we like to call it immune-mediated liver injury from checkpoint inhibitors, which is a mouthful. So ILICI, I-L-I-C-I, I think is a little easier to say. So what is ILICI? Well, it's liver injury in the setting of checkpoint inhibitors. And so it's certainly more common than I think people realized. And as these checkpoint inhibitors are being used for so many different tumors and earlier stages, we're just really seeing a lot of it. And, the overall incidence, if you do, say, a prospective study of 100 cancer patients getting one of these agents, it's as high as 10 to 20%. So it's actually pretty common. The most common are skin reactions, followed by colitis, and then liver's a third, but fairly common. And it can occur with any of the checkpoint inhibitors, whether it's a CTLA-4, PD-1, or anti-PD-L1. But it's more common when you use the anti-CTLA-4, which is most frequently ipilimumab, combined with another checkpoint inhibitor. And it can also be more severe, particularly with anti-CTLA-4. So I think most practicing GI and liver specialists are going to see this in their clinical practice going forward.
Yeah, I agree. It's like a double whammy, right? When you get both of them.
Absolutely.
So one of the other things I think that, people out in practice, when they come across these patients, they always have to consider, we talk about DILI being a diagnosis of exclusion, and LEC is no exception to that. What specific diagnostic tests do you usually recommend for patients when a clinician comes across this consult?
Yeah, I think, kind of the standard workup. So first, I would always go back and ask you to look at the baseline LFTs before the medicines were started, and also whether or not there was, liver involvement from the tumor. And the reason I suggest that is that we actually published a paper a few years ago on Pembro, and we took actually 400 patients who got pembrolizumab in our center from multiple tumors. And we actually found that DILI wasn't the most common cause of liver injury. It was other things like progressive tumor in the liver, sepsis, and other things. So certainly looking at this tumor stage is important, but when a patient presents to you with abnormal LFTs, assuming they were normal pre-treatment, I think we have to do due diligence and look for common things, right? Hepatitis B, hepatitis C, and a repeat imaging is really critical here because the patients can oncologically progress in the liver, and you don't want to be treating progressive cancer with immunosuppression. Also, they can get biliary tract involvement from the checkpoint inhibitor, which is kind of interesting, albeit rare. Or they could get vascular involvement from the tumor, like a thrombosis and so on. So I think basic virology testing of Hep B and C testing, and also a really good contrast-enhanced CT and or MRI is what I do. And I try to do that before we pull the trigger on steroids. But as you know, this is a collaborative care model, and our oncologists have oftentimes done that before they call us.
Yeah, absolutely. And actually, you mentioned the biliary tree, so I just want to pose this question to you. Recently, and I know people like Dr. Bjornson and others have reported this, and we've seen this, where there is this sclerosing cholangitis, this odd secondary sclerosing cholangitis seen with the checkpoint inhibitors. How often do you see that? And can you teach the audience a little bit about that? Because people always think about hepatitis and don't consider that it could give you a cholestatic injury.
Yeah. Well, we're enrolling these cases into Dylan, and when we just recently looked at the first 56 patients with checkpoint or Alissi, two of them end up having sclerosing cholangitis. So I think the overall incidence is pretty low.
Mm-hmm.
It's like, maybe 1 or 2% of all the Alissi cases are missed secondary sclerosing cholangitis, but it's an important minority because they do not respond to immunosuppressive therapy. And if you don't think of it and get the MRI and the MRCP, you will just keep treating them with more and more immunosuppression. The labs aren't normalizing, and it's because it's a biliary tract problem. And so I think it is important to be aware of it, albeit rare, to look for, because your management as a treating physician will change. You won't keep using endless steroids and CellCeps and so on. You may actually go to endoscopy with an ERCP if you have dominant stricture or non-responsive labs to actually treat the patient. So I think it's an important caveat.
Absolutely. It changes your management. So I guess final question before we wrap up. You mentioned steroids, you mentioned mycophenolate. How often are patients steroid responsive, and what is your go-to second-line therapy?
Yeah, so we talk about the grading of this injury, and there's the CTCAE, that's the oncology trial network grading, the grade 1, 2, 3, 4. Grade 1 is 0 to 3 times, grade 2, 3 to 5 times, and so on. Most patients with very mild liver injury may get better with doing nothing, and it's hard to sit on your hands, but sometimes it's the best thing to do. But most patients with grade 2 or 3, where the numbers are higher, if they're not improving after waiting 3 to 5 days, then oral steroids would be the way to start. And with oral steroids, 1 mg per kg, about 80% of patients will respond. And then you want to work with the oncologist to taper them off over, say, 6 to 8 weeks. However, that means that 20% won't. Mm-hmm. And my personal preference is to do a liver biopsy in steroid non-responders, assuming that you've done the imaging and the viral workup. Because if it's something else, you don't, again, want to be giving more and more steroids. And the biopsy could show you, things that you weren't thinking of, right? Like, opportunistic hepatitis from herpes, CMV, and so on. Or microscopic cancer throughout the liver, which, again, would not respond to more immunosuppression. So I like to get a biopsy when they're a steroid non-responder before upping the ante to the second line, which is CellCept. CellCept is generally preferred over Imuran because it's a more rapid onset in terms of action if it's going to work. And that works in about 80% of the non-responders. So, majority of patients will respond either to initial steroids or CellCept. When they're real severe, and this is uncommon to have, for example, an elevated bilirubin or high INR, I would strongly advise to hospitalize that patient so you can get the imaging quickly. If you're going to do a liver biopsy, you get it within a day or two and you can move things along. Because there have been rare cases of progressive fatality from the hepatitis. Again, low incidence, 1-2%, but it can happen in a patient who's otherwise tolerating the immunotherapy. So I think anyone who has an elevated bilirubin and INR, that should ring a bell, hospitalize, get the MRI, get the biopsy to move it along. And they're oftentimes going to be getting IV steroids in that subgroup.
Yeah, fantastic. I completely agree. When in doubt, do the biopsy. If they're not responding, there's something fishy going on. You should do a biopsy. I think that's it. Short but sweet. Thank you for joining us on behalf of all of us at the CLD team. I hope you found this video on immune-mediated liver injury from checkpoint inhibitors useful. And for more information about this topic and other great articles in the CLD hepatotoxicity series, please visit us at www.cldlearning.com. Thanks again for watching.